Hello, everyone, and welcome to our latest podcast interview. I've been fortunate to know Dr. Neil Area for some 15 years now, and I could spend hours talking about his many accomplishments and involvements. So I'll post his full bio to the website for you to read. And for now, I'll just mention a few highlights most relevant to our discussion today. So Dr. Area is a family physician in Kitchener, the president of the Canadian Physicians for Research and Education in Peace, and chair of the Pegasus Global Health Conference. Dr. Area is also founding director of the Kitchener-Waterloo Refugee Health Clinic and was lead physician developing the Psychiatric Outreach Project, providing mental health for those homeless or at risk at St. John's Kitchen in Kitchener, tasks which led him to receiving the College of Family Physicians of Canada Geeta Gupta Award for Equity and Diversity, among other recognitions and awards. Dr. Area is known nationally and internationally for promoting health of underserved populations, and along with Dr. Thomas Pigott, who we met a couple of weeks ago, is editor of the text Underserved, parts of which you'll be reading in this week's lesson. So Dr. Neil Area, thank you so much for joining us today.
Thanks, Janet.
I was wondering if we could start off by just asking you, as a family doctor, already seeing kind of a general cross-section of the population, why did you become interested in working specifically with underserved populations?
Yeah, I'm not so sure that I really looked at a particular interest in the populations. In many ways, it came to me. My regular family practice is or has been fairly multicultural, but otherwise I wouldn't say it involved people who were more vulnerable or marginalized. When I went into medicine, it was after doing an engineering degree, and I had gone in because I wanted to make a difference that I saw was positive. I did my residency at a multicultural center in Montreal, and so had an interest just exploring the world through practice. But I didn't get involved with things in St. John's Kitchen or the clinic that we have with Reception House until the 2000s. So when I'd been in practice for almost a decade, and at that time it actually came to me. So a grad student who had done some work with me contacted people from the working center. Joe and Steph Mancini, and they had a psychiatrist who was coming from St. Catharines who fell sick, and they were left with basically no medical care for a lot of people who used services of St. John's Kitchen. So I agreed to help by meeting them, thinking I would connect them with other people in the community, and in the end, they ended up getting me. We couldn't really connect with other people. I tried to connect people with public health. So I did that for 5 or 6 years as the physician there. We got another physician afterwards, and then I stopped going. I just went once a week. And something similar happened with Reception House. Knowing people who were leading that, they again approached me, said they had trouble finding family doctors for their patients when they came. Reception House deals with government-assisted refugees only. And so once again, I said, well, I'll connect you with various people. And over a series of a few months, the idea of developing a clinic to screen people initially, and then finding a family doctor very shortly, with doctors feeling more comfortable once the more serious issues had been dealt with, we developed this clinic model, which where we basically discharged most people within 3 months. And that worked well. We've expanded that over the years. But to answer your question very simply, it was more having people approach me and me not saying a flat no. So I think that that often people are afraid to get outside of their comfort zone, and I'm not saying I wasn't afraid to do that, but I didn't let that stop me from exploring things with people.
Great. Well, whatever the reason, I'm glad you ended up there because you've made some great differences in working with various populations that we're discussing today. And I was wondering if we could just talk about each of them in turn. So first, could we talk a little bit about your work with the homeless population or those at risk of becoming homeless, and just what that was like and how you had to modify what might be in a typical family practice to better support that population and their mental health, or anything you want to share about that experience?
Mm-hmm. Yeah, I think that it was a real learning experience for me. In some ways, growing up, even though my father was a teacher, because my parents had come from India with almost nothing and were sending money back to India, we grew up very working class or lower in terms of where the places that we lived, at least initially. And so some of what I saw made me harken back to my childhood. But I basically approached things more with a bit of curiosity. And so in my regular family practice, I tried to do things very strictly in terms of time, and trying to get people to come at a particular time. My appointments would be very focused and relatively short, and we'd have a plan and send people off. That didn't always work with the homeless population, and of course people have a lot more barriers in terms of coming in at particular times, barriers that most people with middle class lives and cars and alarm clocks, everything that a lot of people take for granted. So I probably started off with those feelings. In a regular practice, we bill people for missed appointments. If people don't come in within 10 or 15 minutes of when their appointment starts, we say, sorry, we won't see you. And of course, the kitchen can't function in that way. So I learned a little bit that way, but I think I was prepared to pay some attention to that. Something I didn't expect, and I think that we all have fears when we go into certain settings which are not like what we have. Probably more than half of the people who use the kitchen services would have a criminal record. But basically, I never saw any violence at all in the kitchen. And the kitchen had a policy of really discouraging any type of police presence. And somehow people learned how to de-escalate situations, even though we would deal with people with past trauma that was quite severe, people who were sometimes high. So I think it was more suspending that judgment and even a bit of that fear that I would have even about physical security. So just treating people as other people was probably the biggest lesson I learned.
And do you think that providing that care made a difference in people's lives? Like, is there any examples you can think of where someone was able to, walk out in a different way than they would have if they hadn't got that service?
Yeah, I think to some degree, yes. There's certain things you can't change with medical care.
Yeah.
And people's mistrust of the system and trauma. One anecdote that a nurse practitioner worked with us said was when one of the patients got admitted to the psychiatric hospital, that this person wasn't very communicative, and they were just asking whether he had any medical care or what was going on in his life, and he mentioned my name. And so then they said, oh, well, why would you be seeing Dr. Arya? What's so special there? And so he responded, Dr. Arya is where I'm at. And so she thought that was a very meaningful anecdote. And then the person was psychotic at the time. So she said, you saying Dr. Arya was psychotic where you're at? But this particular person did very well. And I do think that being where people are at is a very important part of the kitchen.
That's a really nice story. Yeah, and I guess some ways you'll never know the difference you made, but I think just having people there to support their needs would be such an important piece of that supportive system that they're trying to create there.
Well, I think what you're saying is that really the physician in that system is important, but the other parts of the system are actually much more important on an individual basis. Sometimes just for external stakeholders, in some ways, having a physician is there. Sometimes it's with regard to financing, but the other parts of the system, from the outreach workers and the people working in the kitchen and the allied health professionals, are probably much more important than a physician in that setting.
And for you, being so aware of how the social determinants of health impact health, it must be sometimes, I imagine it must be sometimes frustrating that there's only so much you can do in terms of prescribing a medication or a lifestyle change when you know that this patient doesn't have a home to go to, or doesn't have, healthy food to expect every meal of the day, or, a dignified job that they feel good about, all those other things that impact our health. So in a way, what you can do is limited, right?
Yeah, no, it is hurtful realizing that there are sometimes only minor differences you can make. It is gratifying, though, when you do make a difference, and probably more so than with the more mainstream populations.
Okay, let's pivot to talk a little bit about your work with refugees. You mentioned a little bit that the purpose of the clinic ended up being more screening when people first arrived, and then trying to find them a healthcare practitioner. Why is that important? What issues do refugees arrive with that require that extra bit of care that maybe someone else in the general community may not feel comfortable providing that care?
Mm-hmm. I think, once again, it is the unknown for people. Most of what we did in both settings was regular family practice, what we would get from our training. There were certain things in terms of medical conditions, infectious diseases, things that are very specifically culturally bound, that we do deal with. But most of that, if a physician were able to take the time, they could look those things up. And now we even have the way of providing virtual consultations, which we do very rarely. The mental health side is certainly quite prevalent in terms of the traumas that people will have faced in terms of what made them refugees, the journey that they go through to eventually get to Canada. And sometimes being here is also re-traumatizing. But we, in our clinic, by and large, at least the first few years, we weren't doing too much directly with that. I think we were just providing an open space. There wasn't much that you could do to fix a person or situation within 1 to 3 months. So it was just that we were there. We did basic screening tests. There are some guidelines which help us to decide what screening tests would be useful. We made referrals. Some people were complex. What your students may not know is, since the early 2000s, Canada has not discriminated against the type of refugee that they take in terms of their medical needs. Prior to that, they could say, you're going to be too big a burden on the Canadian system, therefore we won't take you. And because of that, we end up with some people with highly complex things, of course, HIV, which most family doctors should be able to manage, but also people with amputations, learning disabilities. And so you need not just to have specific knowledge, but to be connected with the system. Right now, we've had the local health integration systems and the Ontario health teams, and then being connected to social workers, and then the rehab specialists. So things that we might know a little bit about, and then beyond that, connection with the school system, for instance, or Kids Ability. So some of those things we may not really use so much as family doctors. So our clinic is able to connect with those types of resources.
So I'm hearing kind of a pattern here where there's been different populations identified, different models that you've worked in to meet their needs. I know you've also done some of the specialized migrant worker health clinics that I have been involved in as well. I'm wondering if in general, do you think that people going into family medicine are well trained in supporting underserved populations, or is part of the reason these clinics are necessary is perhaps because there is that lack of understanding and knowledge of how to well support these populations?
Mm-hmm. I guess the answer would be yes and no, that people are and are not well trained. I think we aren't so exposed, but a large part of it is dealing with people with humility, the introspection part, and recognizing the importance of equity. In some ways, that sort of training is better now than it was 30 years ago when I did my residency. On the other hand, having the ability to learn about things and even having stuff on EDI in terms of our formal training doesn't necessarily make us more sensitive to certain populations, because I can think of many people from when I was doing residency or before who actually just had that innate ability to connect. And so I don't think that the specific knowledge necessarily is the thing that makes you connect. But yeah, I think that it's being able to get out of your comfort zone. There are things in which these populations are not just challenging, but they aren't as financially lucrative to look after. If you look at a fee-for-service model, if you're looking at people who require interpretation, again, taking a fair bit more time to get to the same endpoint. And so a lot of people feel they just don't have the energy for that.
Interesting. So in some ways, having specialized clinics, I think, not only helps to get to know that population and their needs, but may also help to overcome some of these logistical challenges. I know with the migrant workers, for example, meeting them where they're at on their farm or on a Friday night when they're in town shopping is a much more accessible way for them to access care than just asking them to come into a doctor's office in town 9 to 5 during the week when they're working, right? So there's also those issues to think about.
Yeah, very, very much so. So I think with the migrant worker clinics, which you were instrumental in and will has continued to work with, yeah, I think recognizing people's barriers. If you expected them to come in for an appointment at 2:10 and they are relying on their employer to get them into that appointment, and the employer will certainly want them back right away, the employer may hold their health card, although I've seen that happening much less now, perhaps with the clinic outreach. Yeah, it becomes very difficult to reach the people who really need care. And by providing that Friday evening when people are shopping, when the transport goes in, it does make things much easier for people.
And my class hasn't yet been introduced to Will, so I'll let them know Will is my husband. a family doctor who trained with the great Neil Arya once upon a time, and also works at these migrant worker clinics. But I haven't yet brought him in for a video podcast, so maybe next time. Okay, so I want to move on and just ask, has the care for these populations, whichever you might want to talk about, been impacted by the COVID-19 pandemic?
Yeah, I think very much so. And I think any crisis, any hit of any sort always affects people who are at the margins more. We don't have systems that are designed for them. We had an article in Canadian Family Physician in the summer of 2021 that people might look up on COVID and refugee populations across the country. So we had about 9 or 10 authors from different places. And our clinic here deals only with government assisted refugees. So people who are entitled to having OHIP the first day that they get here, if they can go to the office. And they also have support from the interim federal health benefits program. And so the others sometimes don't have that. So there are different challenges there. People did have challenges getting their OHIP cards during the pandemic. But when people come into the country, for much of the pandemic time, there has been the 2-week isolation aspect. And so that people would be in a hotel room. So even if they had severe needs and we were told beforehand, patient must see a psychiatrist within 48 hours or see a cardiologist, they couldn't get that.
Wow.
But beyond that, you had social services also working virtually. You had people who had the various language barriers in terms of understanding precautions, which they couldn't. Information wasn't always put in various languages. Our refugee clients sometimes weren't always technologically literate, and even if they were, they didn't have the actual technology with them. So having virtual services, even if they were somehow available to them, wouldn't always work. Refugees often, and not so much ours, but if you were a refugee claimant, if you were working at an irregular job, taking off time became more difficult. Refugees were probably at higher risk, and there were studies in Toronto which showed that because of people working in the service industry as well as chronic care homes. So people were and taking public transportation. So people were more at risk. They did get COVID more. They weren't able to get to treatment as easily. So there are many barriers that people faced during the time, and then of course the other socioeconomic barriers. Kids also weren't going to school often because of parents' misinformation. So lots of different challenges that COVID posed.
Yeah, thank you for summarizing what was a really complicated and challenging time. I want to now shift our discussion a little bit, because although this lesson is focused on underserved populations in Canada, I know you've also done a lot of work internationally and in other countries where poverty, war, health disparities, they may be even more stark than they are here. And you've also done a lot to raise awareness about global health, environment, and peace issues through your leadership with the Pegasus Institute, which I'll link to on the website. So I just want to ask, why do you think it's important for Canadians to understand the challenges facing people living beyond our borders? And what role do we have to play in building a more peaceful and just world? And I know that's a huge question, and you can tackle that however you like.
Yeah, no, I feel like I'm at a Miss America pageant here, that I believe in world peace. But to be honest, I guess we're in an interconnected world. So what does happen outside of our borders influences what happens in our borders. Many issues that we face here with Indigenous peoples and refugees are very similar to in other areas. There are parts of this country too which have the same sorts of health stats as people in other countries. So we are all interlinked, and then with the transportation issues too, that with people just being a few hours away from places that once were very remote, that there is that connection. We also have the economic system, which makes us interconnected with movements of capital. But I think we still have a bit of that savior mentality here,
Yeah.
that we're doing good to help with things in the rest of the world, but often we're really truly responsible by our policies or actions with what is happening in other parts of the world. I think with regard to climate change, many people of the younger generation are recognizing things in terms of climate justice, that the different risks that people have of extreme weather events are related to what we've done in the past in the global north, our consumption patterns. We're also recognizing in terms of so we may owe some climate reparations, as people are talking about, but also people in the global north have benefited from a certain economic system, taking things, extracting things from places in the global south, and then leaving much of the toxic legacy down there. But so when we look at what is called odious debt, for instance, that we lent money to kleptocrats that we either put in power or kept in power in other countries. They took loans that were at very high interest rates in the 70s and early 80s, and then we expect them to pay back things to us. So there are many ways in which we have been interconnected, and so Pegasus deals with some of those issues, even in terms of war and peace issues. We support certain regimes that provide us with certain things, whether it be markets or resources such as oil, and then we condemn other countries who make decisions which are made under similar things, and again, countries that supposedly are supporting Russia today. I realize this won't be topical in a couple of years, but we'll find another regime where we condemn others for supporting those. So Pegasus looks at global health at its nexus with peace and sustainability, tries to look at principled ways of dealing with equity and justice issues, and tries to be more culturally humble. So I welcome people to join us.
Wonderful. Well, as you know, I've been a big fan of Pegasus over the years and have loved taking part, and I will link to the site and encourage everyone interested in these issues to look to learn more and get involved as well. And thank you. I feel like you summarized my whole international development 4-year degree in 2 minutes. So that was a really you definitely win the Miss America competition if it was based on succinct answers, adequately summarizing really complex global issues. Okay, so my last couple of questions here. We have a number of aspiring healthcare professionals or policymakers here in the class. What would you like them most to consider when they're moving forward with their careers in terms of how they can keep health equity at the forefront of their minds and promote these issues as they go on?
Mm-hmm. I do find it tough to give advice to others. And there are many paths to promote health equity. So I don't think that there's one particular way. And there are also, in terms of people through their careers, there are some people who have a lot of energy at a particular time, and others who do things more consistently. Some people can do things in a small way. But I think it's just approaching other people as being like us. When you look at how you deal with somebody, look at them as your brother or sister or parent or child, and just, yeah, be humble with what you don't know. Be curious in terms of trying to find out what is responsible for people coming in to see you. Try to withhold judgment, at least at the beginning, to try to walk in somebody else's shoes. Those are basic principles.
Well, for someone who doesn't like giving advice, you give great advice. So really important messages to take forward, and something I think all of us forget, not just in professional situations, but as we walk down the street and pass people we might not know, and we might form judgments all the time, right? Final question, because this is a health policy class, are there any particular policy changes? I know there's probably a million you can think of, but are there any that you would really like to see to better impact any of the populations you've talked about today?
Mm-hmm. No, I hope that some of your students will end up in the policy arena. They'll be willing to listen to people like me on the front line. Sometimes people at a policy level make decisions that will impact a lot of people without really consulting with people who might know more about those impacts. So I think if even in policy circles, you start to think about people as being those close to you, I think that can be helpful. Sometimes it is that the one hand knows something and the other hand doesn't, and the other hand is the one making decisions. So sometimes, like say our federal government will make policy inviting a lot of people over, but then those responsible for settling people are at a provincial or municipal level, and they haven't thought that far ahead in terms of what needs to be done. So sometimes you do have to act in an emergency, but always be prepared to listen and to try to do what's best for those whom you're supposed to be serving.
Super, thanks. Well, that's all my formal questions. Is there any other thing you wanted to add that you feel like you didn't have a chance, or do you think we covered the main points?
No, I think that we got pretty much everything. Thanks, Jan.
Great. Thank you so much for your time today. I really appreciate it, and we'll link to everything we've mentioned so the students can read a bit more.
Okay.